Well, is that loud enough? Okay. Thanks for the introduction, George, and thanks for coming, everybody. Today we're going to talk about vitamin D, the vitamin of our time. I started medical school, as George said, in 2005, and I'm pretty confident that my years as a student and as a resident directly coincided with the meteoric rise in popularity of this substance. I've been puzzled by this vitamin for years now, by issues such as whose levels I should be checking and who needs what dose, and whether the whole program of testing and treating made any difference to patients at all. It was this confusion over how best to give vitamin D its due that led me to do some digging and put this talk together. I should say up front, I'm not an expert on vitamin D. I'm not a research scientist or an endocrinologist. I'm just a humble family doc man. What I'll present comes from my own survey of recent medical literature on the subject. I'm not really here to critique the primary literature. Much smarter and more skilled people than me have already done that, and I will present some of their findings here today. To start, we'll take a quick look at the current vitamin D informational landscape to make explicit some of the reasons the average medical provider, like me, may harbor some perplexity over vitamin D. I'll then talk through what this vitamin is, where it comes from, and what it does in our bodies. Next, we'll move on to reviewing the current state of the evidence on the highest impact 11 vitamin D related topics I could come up with. I'll then close with some summary suggestions, and hopefully we'll have a few minutes for questions. Okay, so I used this word hype in the title of my talk. I should probably explain myself. I think there are at least three separate definitions at play here. The first is hype as a noun, and this is the obvious one. Now, reasonable people may disagree over whether vitamin D's publicity has been exaggerated, but to say that there's been hoopla surrounding it is definitely fair in my opinion. There are two verb definitions of hype that probably best describe what I did by naming this talk what I did in an effort to get you here today. Flamboyant methods, dramatic methods, questionable methods. I'm definitely guilty as charged here, folks. There's still time to leave if you want. The third and my favorite definition of the term comes to us from urbandictionary.com. You'll note first that this definition isn't categorized as a part of speech at all. Is it a noun? Is it a verb? Is it both? Or is it operating in some strange fluid dimension of usage? You'll also note the juxtaposition of absolute deadpan clarity in the definition itself. When someone gets excited about something, it's so good. But the best part of this definition is the example sentence that the author gives. Damn, you hype. Calm down, homie. All right, enough playing around. I'm clearly hype, but I need to get moving here. So what's all the hype about? Well, in the last 10 years or so, low vitamin D levels have been linked in observational studies to all manner of human ailment and suffering. Cancers, diabetes, autoimmune diseases, and metabolic diseases have all been tied to lower vitamin D levels in case control and cohort studies, as have cardiovascular disease, hypertension, poor functional capacities, and even death. These are big, important things. This is the primary source of the excitement, or the hype, if you will. We've been inundated with these observational studies in recent years in medicine, and this tsunami of data has brought an even larger surge of editorializing in both the medical literature and the lay press. I recently did a quick PubMed search for papers with the words vitamin D in the title. Kind of a crude surrogate for vitamin D publication activity, but illustrative. PubMed is this really slick feature where it will automatically tell you the number of papers in your search results that were published each year, and you see that data presented graphically here. It was right around 2005 that the volume of publications addressing this vitamin really started to take off. Interestingly, it looks like 2013 may have been the peak year at just over 1,400 articles, with publications falling off rather dramatically the last 2 years. Time will tell whether this trend continues. I found one neat paper from the journal BMJ Open that looked at coverage of vitamin D in major newspapers. Now, those of you who peruse the Toronto Globe and Mail as often as I do, I know you're out there, probably already know of that paper's special exuberance for the subject. But across many major Canadian, US, and UK newspapers, vitamin D has received no shortage of attention. Despite, or maybe in light of all this press, confusion over how to incorporate vitamin D into one's own practice is natural. Let's consider some of the reasons that may be so. First, let's return to that list of diseases and bad outcomes to which vitamin D has been linked. No doubt, this is like an all-star team of things we want to avoid, and anything that gets identified as an apparent independent risk factor for so many negative things should get our attention. Now, it may be that vitamin D is critical to human health, but remember, observational studies, even prospective cohort studies, do not necessarily establish causation. As we'll discuss later, we've been burned in medicine before, and more than once, in our enthusiasm for trying to modify apparent risk factors for diseases. In reality, risk factors may be causes of diseases, but they may also be markers of something else. They may be innocent bystanders. So it's perfectly understandable that one might not know what to do with all of this observational data. An optimist may see a panacea in the making. A skeptic like me may catch a slight odor of snake oil. In my observation, clinical practice when it comes to vitamin D is just all over the place. I'm sure many of you have observed the same. Here is a partial list of the clinical uses to which I've seen vitamin D put in the last few years in my own less than scientific perusal of charts and progress notes. None are necessarily illegitimate, but they certainly are diverse. And I think that any medical technology that's put to such a diversity of uses should be subject at least to a modicum of scrutiny. Now, vitamin D is somewhat unique among important substances in human biology, which is probably another of its features that may confuse us. We'll come back to this graphic in a minute. I'm showing it here just to emphasize the weirdness of this vitamin. You can see that vitamin D isn't just one thing. It exists in at least 5 different forms. It also relies on the sun for a key step in its synthesis, which is common in the plant world, but not so much in the animal world. The sun step can be bypassed if one eats enough of it in a different form. And it requires the interplay of at least 6 different organ systems to do its thing. So it's complicated. And then we have all these formulations and doses to keep track of, which isn't straightforward either. Which one do we give, D2 or D3? Is one form cheaper, more effective, or safer? Should I write for 400 units, 1,000 units, 50,000 units? Do I have to order calcium too? The possibilities are kind of endless. Finally, we have the vitamin and supplement industry, a force to be reckoned with, influencing patient habits and probably to some degree our own prescription habits. According to The Economist, there were over $10 billion in vitamin sales alone in America in 2014. And worldwide, the broader supplement industry recorded over $88 billion in sales that same year. Yes, Americans love gummy bears. About half of us take at least some vitamin or other supplement regularly, according to that same Economist article. The trouble is, as many of us know, our FDA has very little regulatory authority over this industry. And vitamins don't need to prove safety or efficacy the way other pharmaceuticals do in order to make their way into medicine cabinets and onto store shelves. So I don't know. I'm not sure whether this stuff is any good or not. Just like he's not sure Cruz is a native-born citizen. Doctors are confused. Constitutional lawyers are confused. It would be understandable if we just threw our hands up and moved on to a simpler topic. But my friends, troubles be damned. This campaign is rolling on. Let's get down to some basics. First, what does this vitamin do? Well, as most of you know, vitamin D is one of the 4 major fat-soluble vitamins, along with A, E, and K. It exists in numerous forms in our bodies. Pre-vitamin D, D2, D3, and 2 forms listed here.25-hydroxyvitamin D is the major circulating form, and 1,25-dihydroxyvitamin D is the major biologically active form, at least to the best of our current understanding. While this vitamin probably plays a host of roles in the body, as its receptors have been found in most cell types, it has a very robust portfolio of work in the calcium, phosphorus, and bone homeostasis departments. As I noted earlier, there are a whole bunch of organs involved in the vitamin D, calcium, and phosphorus pathway. Now, bear with me here. This is probably the most technical part of the talk. Pre-vitamin D is made from a cholesterol precursor in the skin in the presence of UVB radiation, and this is converted quickly by heat into vitamin D3. D3 and D2 can both be obtained from the diet as well. These vitamins are either packaged into little microscopic balls of fat and protein called chylomicrons and transported to the liver, or they bind to a protein called, very creatively, vitamin D binding protein and ship off to the liver or to fat cells for storage. In the liver, D2 and D3 are converted by an enzyme to 25-hydroxyvitamin D. This main circulating form then reaches the kidney, where it is converted as needed to 125-dihydroxyvitamin D. Several factors, including calcium, phosphorus, and something called fibroblast growth factor 23, regulate how much vitamin D is converted to the biologically active form. This active form of vitamin D goes to several places, to the small intestine and the kidneys, where it increases the efficiency of calcium and phosphorus absorption, to the parathyroid glands, where it turns down parathyroid hormone production, and to bones, where it causes cells called osteoclasts to mature from precursor versions of themselves. These cells, in turn, release calcium and phosphorus from bone, helping maintain optimal serum levels, which in turn helps to mineralize bone. Okay, sorry, that was a mouthful. Let's talk about the sun for a minute. Now, theoretically, one can make all the vitamin D one needs under the right conditions, even at northern latitudes. The trouble is that UVB exposure and efficacy are affected by a host of variables listed here. Geography, atmospheric conditions, and skin are all factors. Melanin, the skin pigment, sort of competes with vitamin D precursors for UVB radiation, meaning it takes significantly more exposure to UVB, probably something like 3 to 5 times as much, for a darker skinned person to make a similar amount of vitamin D3 as it does in someone with lighter skin. There have been some clever studies done that attempt to pin down how much sun exposure is needed to make sufficient vitamin D in a given place at a given time of year. One study estimated that in Boston, from April to October at noon, it would take 3 to 8 minutes of sun exposure over 25% of the body surface area of someone with Fitzpatrick type 3 skin to generate 400 units of vitamin D. So that's pretty easy to translate into a recommendation for patients, right? Another study of Canadian towns and cities found that in Montreal, which is about 1.3 degrees of latitude south of us, one could theoretically generate 1,000 units of vitamin D daily, even in the winter months, in November, December, and January. But it would take a fair-skinned or type 2 skinned individual more than an hour exposure over an eighth of his or her body surface area to do it. So it obviously becomes impractical in the wintertime. Add to this fact that UV exposure in general is the prime culprit in skin cancers, and you shouldn't be surprised to learn that blanket recommendations for sunlight exposure to optimize vitamin D status are very hard to come by. That said, in one article I found on the NIH website, it was suggested that 5 to 30 minutes of exposure between 10 a.m. and 3 p.m. to the face, arms, legs, or back without sunscreen at least twice a week is effective. You should also know that we can't develop vitamin D toxicity through excessive sunlight exposure. The heat from sunlight exposure quickly destroys excess pre-vitamin D and D3. I couldn't figure out what counts as excess. I had yet to see a published number for the maximum possible amount of vitamin D one can manufacture in one sitting. Okay, now, D2 versus D3. Is there a major difference? Well, D2, or ergocalciferol, is made industrially through the UV irradiation of a yeast product. You can purchase lower doses over the counter, but the higher dose formulations, which include 8,000 unit solutions and 50,000 unit capsules, are prescription only. I found this website called lowestmed.com that offers discount prescription coupons for bigger retailers. And it looks like the cash price they can get you is about $9 to $17 for a 3-month supply of the high dose capsules. It's really not that bad. D3, or cholecalciferol, is typically made industrially from lanolin, which is a sheep's wool product, but I was able to find vegan versions made from lichens as well. There's a huge variety of over-the-counter dosage forms available, everything from 200 units up to 10,000 units. It's even cheaper than D2, with online retailers offering 3-month supplies starting at about $3 and year-long supplies for less than $10. The natural question to ask next is whether one form is superior. Well, this study from the VA published last year suggests that it depends on what you're looking for. Researchers reviewed the charts of about 6,400 veterans who had vitamin D monotherapy initiated between 2005 and 2010. About 90% of patients were men, and the mean age was 67. They grouped subjects into quartiles based on daily dose of vitamin D for their analysis. What they found was that D2, or ergocalciferol, dosed at an average of about 11,000 units per day, was associated with the largest gains in serum vitamin D levels, with about a 20 nanogram per milliliter rise over about 3 months. Contrastingly, at average doses from 600 to 2,700 units of vitamin D3 or cholecalciferol, levels rose by 8 to 12.7 nanograms per milliliter over 4 to 6 months. For subjects with the lowest baseline vitamin D levels, all of which were well under 20 nanograms per milliliter, it took a much larger cumulative dose of D2, about 3 to 5 times as much actually, to get patients' vitamin D levels up over 30 nanograms per milliliter. Additionally, they found that adherence, as measured by something called the medication possession ratio, was much higher in the D3 than the D2 group. So, in summary, D2 may produce the most time-efficient rise in vitamin D levels, but it comes at the cost of dose efficacy, which is of unclear importance, and also poor adherence in this population. Measuring vitamin D came up in this study, so let's turn to that issue next. In general, the test you want is the 25-hydroxyvitamin D, which is the major circulating metabolite as we talked about. In the Choosing Wisely campaign, the Endocrine Society really discourages measuring the 125-dihydroxyvitamin D level in all but a very few specific clinical situations, which are hypercalcemia with a low PTH level, and in some patients with end-stage renal disease, which is probably best left to the nephrologists. Now, lab testing is an area of real concern in the vitamin D world. While there's general agreement that levels below 10 to 12 nanograms per milliliter are considered deficient, there is an ongoing and perhaps insoluble debate over what to do with readings between 20 and 30. Some argue that levels of 10 to 30 are quote-unquote insufficient and need aggressive action, while others maintain that levels below 20 are deficient or insufficient, but that levels of 20 to 30 are actually okay. This is a little bit obscure, but the debate grows out of varying interpretations of what happens to two physiologic parameters at vitamin D levels between 20 and 30. Parathyroid hormone, or PTH, release, and the efficiency of calcium absorption in the intestine. To chase a tangent for just a minute, if you delve into the vitamin D literature at all, you will inevitably run into some article written by this guy named Michael Hollick at Harvard. He's a titan in the field. He's published a lot of basic science research on vitamin D, and like half of the review articles on vitamin D too, so everyone references him. Now, he has presented data showing that PTH levels plateau at 25-hydroxyvitamin D levels of 30, and that PTH rises as vitamin D levels drop below this. This is why he defines insufficiency as a serum level less than 30, and he has proven to be very influential. The trouble is, since Hollick argued for that cutoff of 30, data has come out in several other places showing that the PTH response at 25-hydroxyvitamin D levels between 20 and 30 is actually quite variable. That on average, there's only a very small rise in PTH in that interval, and that PTH levels actually stay within lab normal range despite that rise. So I personally see little reason to use 30 as a cut point for insufficiency, but that's also not my call to make. What you need to know is that there is not a consensus on what to do with levels between 20 and 30, and that you should not feel obligated to use Hollick's standard of 30. As for toxicity, and yes, there is such a thing as too much vitamin D, it's defined as levels above 150 or above 200, depending on where you look. You should be aware of a few other things here. First, the cost of a test, while not exorbitant, is not a pittance either. We all know that $5 prescriptions can be burdensome for many patients. $96 lab tests sure must be too. Medicare reimburses about $40 for the test, and thanks to Caramore for that information. Bear in mind that Medicare has a list of diagnosis codes it requires in order to cover the test. It won't cover the test for any old reason. The Vitamin D Council, which seems to be the most prominent vitamin D advocacy group around, offers a home test for $50 for those who are truly determined to know their status. You should also know that there are several different lab assays in use, meaning totally different lab methods are used to come up with a vitamin D concentration. This is a really important thing. Accuracy and precision remain worrisome issues in testing because of this, and unfortunately there's no generally accepted lab reference standard yet. Variations in readings of up to 25% between assays and up to 10% on the same assay have been observed, which is kind of a big deal when treatment decisions are based on these results. It's also a big deal when the studies that guide our practice use different lab methods. so it's hard to compare levels between studies. Additionally, the season of the year matters for reasons we discussed earlier. Now, vitamin D testing is blowing up right now. Craig Bell, the director of our lab here, told me that he'd seen a dramatic rise in orders over the last 5 years. With the recent switch over to new software in our lab, I can only get data from last year, but there it is at the top. You can judge whether you think that's enough for too many or too few tests for Missoula. Published survey data referenced by the USPSTF showed that 50% increases in testing over just 1 year were very common in the late 2000s in labs across the US. The province of Ontario, Canada, saw year-over-year growth in testing of greater than 200% in another study. And Liverpool in the UK saw a 10-fold rise in testing in a group of primary care practices over just 5 years. Again, not a huge surprise given that informational landscape we occupy, but these numbers do make me wonder whether we've gotten just a wee bit ahead of ourselves here. How much vitamin D do we need anyways, and can milk meet my needs? Well, the most widely circulated guidelines come from the Food and Nutrition Board at the Institute of Medicine. These numbers are also controversial in some circles, with some folks arguing we need much more than is suggested here. But basically, 400 units a day in infants, 600 units a day for the vast majority of people ages 1 to 70, and 800 units a day for the 70-plus crowd ensures vitamin D adequacy in 97 to 98% of the population. If you feel otherwise, or if one of your patients is known to have a condition associated with a deficiency, go ahead and recommend higher doses. Just don't go over those tolerable upper limits in the right-hand table for long. Staying at or below those doses seems to ensure serum levels of 40 to 60 nanograms per milliliter, but no greater, which is plenty high. Despite the fact that toxicity ensues at levels above 150 or 200, there's been some published data that suggests adverse outcomes may start to accrue at vitamin D levels above 50 to 60 nanograms per milliliter. As for foods, we're basically looking at fatty fish, eggs, beef liver, and some mushrooms as the primary naturally occurring sources. Orange juice, dairy, and breakfast cereals are fortified with vitamin D as a public health measure, and it was this fortification starting in the 1930s that led rickets to become as rare a disease in this country as it is now. So unless you're doing cod liver oil or eating a lot of salmon and swordfish, it is hard to get enough vitamin D from diet alone, but it's not impossible. And there you see the numbers for the gallon challenge. Tons of vitamin D in that, so be my guest. The next question is, what does vitamin D deficiency look like clinically? Well, in an era in which what we consider deficient has done some creeping, low vitamin D levels may not lead to any symptoms, signs, or lab abnormalities at all. There are two classic vitamin D deficiency diseases. Rickets, the form generally found in infants and small children, is seen here in the picture on the left. This is actually a 12-year-old from the Ukraine in a New England Journal case presentation. She was obviously failing to thrive, had bilateral valgus deformities in the tibia and fibula, severe thoracic scoliosis, and costochondral swelling. The picture on the right shows her after bilateral tib-fib osteotomies and spinal fusion. So rickets is described here. Very, very rare in the US, as I said. Case reporting is not mandated, so we don't have exact numbers, but I saw contemporary estimates on the order of 9 cases per million. When it does happen, it's often in breastfed, darker-skinned children because breast milk contains very little vitamin D, and darker skin, as we discussed, has a harder time making vitamin D. There are several forms of rickets, a number of which involve inherited or acquired errors of metabolism. The central problem in rickets is failed bone mineralization. There are several classic skeletal features, one of which, called the ricketic rosary, where the costochondral junctions bulge, is shown on the right. Once the growth plates are fused in older children and adults, severe vitamin D deficiency can cause osteomalacia. This isn't the same as osteoporosis, but the two can and often do overlap. In osteomalacia, vitamin D deficiency leads to secondary hyperparathyroidism, increased bone turnover, and bone porosity. Decreased bone mineral density is typically seen, but unlike osteoporosis, osteomalacia may have symptoms of dull, aching, or throbbing bone pain unrelated to fractures, as well as muscle pain and weakness. Pressing your thumb on the shin or sternum of someone with osteomalacia may reveal significant tenderness. This disease is much more common with vitamin D levels below 10 nanograms per milliliter. In the picture, you can see the classic radiographic finding of the rugger Jersey spine with biconcave vertebrae. Here you see significant genu valgus deformity on the right in someone with osteomalacia. On the left, more subtly, there are some pelvic insufficiency fractures at the white arrow. Kind of hard to see. The black arrow shows a condition called protrusio acetabuli, where the acetabulum and femoral head migrate medially from their normal position. Osteomalacia is one cause of that. All right, so that was a very rapid tour through the basics of vitamin D. What I'd like to do now is review the current state of the evidence and 11 clinical questions that should have broad applicability in primary care. In all of these cases, I'll present the highest available level of evidence I could find, mainly systematic reviews from the Cochrane Collaborative and the U.S. Preventive Services Task Force, but also some guidelines from Essential Evidence Plus and a few large randomized controlled trials. Question number 1. In light of all the negative health outcomes that have been associated with lower vitamin D levels, should we be screening asymptomatic, reasonably healthy people for deficiency? And the answer is no. Now, I recognize this may run counter to how some people practice, but hear me out. The USPSTF, the primary group that promulgates recommendations on preventive health services in this country, gives vitamin D screening an I designation, meaning there is insufficient information to fully assess the benefits and harms. Going one step further, the American Society for Clinical Pathology, as part of the Choosing Wisely campaign, advises against population-based screening. Why is this? Well, there are many reasons, the primary of which is the lab test itself with all of the limitations we discussed earlier. Beyond that, data showing improved outcomes and limited harm with screening and treatment based on screening results is simply lacking. There is also concern about both overdiagnosis and underdiagnosis because of the lab test issues. We also don't have any idea what to do about populations such as African Americans, in whom 25-hydroxyvitamin D levels are 2 to 9 times more likely to be low than in Caucasians, but in whom fracture rates are only half that of Caucasians. The ASCP statement shown here offers an alternative to screening. Encourage patients to get a little sun in the summer, and recommend over-the-counter supplements if you feel compelled. Second question, are there special groups in whom it would be rational to screen? And the answer is yes. If you think back to that vitamin D metabolic pathway we reviewed, this makes sense. Diseases and medications that disrupt the synthesis of vitamin D or interfere with the absorption of it and its precursors from the diet increase the likelihood of deficiency. You won't find many guidelines on screening frequency except in the case of kidney disease. Just as in the general population, there isn't much good randomized control data out there yet to guide our practice. But in these populations, it's not unreasonable to check if you think of it, and even more so if you clinically suspect deficiency. Now, I should note that the Endocrine Society has published guidelines on this topic, but I would respectfully recommend being very careful about incorporating them fully into your practice. I say this because even though they specifically suggest avoiding population-based screening for vitamin D deficiency, there are so many high-risk groups in whom they do recommend screening, and these include the obese, and that's already 35% of the population, pregnant women, Hispanic and African American people, elderly at risk of falls, and plenty of others, that in effect they're recommending screening for a majority of adults. I personally can't get behind a recommendation like that. Number one, because it's way too costly, and number two, because its efficacy is completely unproven. Next question. Does taking a vitamin D supplement lead to some overall health or survival benefit? Well, as things look right now, there is a small mortality benefit. A 2012 Cochrane review of 56 randomized controlled trials involving over 95,000 people addressed this question. The population leaned heavily female, and there was a large dropout rate overall. Nonetheless, the authors found a small but significant reduction in mortality with groups on vitamin D therapy. We're only talking about a 0.2% absolute risk reduction, but in large populations, this is meaningful. Interestingly, when the authors broke studies down by the type of vitamin D therapy, only D3, or cholecalciferol, was associated with lower overall and lower cancer mortality. D2 and calcitriol showed no mortality benefit at all, and no form of therapy showed a cardiovascular mortality benefit. Calcium was used concomitantly in many of these studies, and there appeared to be a small increase in the risk of kidney stones with combination therapy. I didn't see an analysis of vitamin D alone in the review, and I'm not sure there was adequate data to comment on its role with kidney stones. Another point the authors make is that the mortality benefits seem to be robust across multiple subgroup analyses. Vitamin D dose, baseline serum vitamin D levels, gender of study participants, presence or absence of calcium therapy, and likelihood of bias all failed to undermine that mortality effect. So to summarize, over 4 to 5 years of therapy, giving supplemental vitamin D appears to slightly lower the risk of dying. In the best case scenario, there is a strong benefit, and in the worst case scenario, there's no benefit at all and perhaps worse mortality. D3 shows overall and cancer mortality benefit. D2 shows no mortality benefit. The number needed to treat to prevent 1 death over 5 years is 150. Based on my back-of-the-envelope calculations, 1 life could be spared with $7,500 worth of supplements bought on the internet. That's really a steal as far as medical interventions go. It's pretty cool stuff. Now that we've seen D3 may reduce cancer mortality, the next question becomes whether vitamin D can actually prevent cancer. As we touched on earlier, deficiency has been linked to a whole bunch of cancers. The answer for now is no. Another Cochrane review guides us here, this one from 2014. Up until the time of the review, 18 randomized controlled trials had been done. Just over 50,000 participants, mainly women living in the community. Studies compared any form of vitamin D, mainly D3, to placebo for an average of 6 years. No significant benefit in terms of cancer occurrence was seen. The relative risk of cancer was 1 in the vitamin D group. The authors also note that their analysis suggests that if there really is a benefit to therapy out there in the world, it's likely very small. Another big randomized trial was reported just last year in the New England Journal. In this study, 2,259 adults ages 45 to 75 who had had an adenoma removed on colonoscopy in the last 4 months were randomized to calcium, vitamin D3, combination therapy, or placebo. After 3 to 5 years of follow-up, adenomas, which are precursor lesions to cancer, were found in all 4 groups at similar frequency. So no benefit to D3 in this population, at least at this 1,000-unit dose. Next question. Vitamin D is critical to bone health, so does therapy prevent fractures? The USPSTF still gives an I recommendation of vitamin D for fracture prevention, saying there is insufficient evidence to assess benefits and risks. They also give a D recommendation specifically to vitamin D doses of 400 units or less and calcium doses of 1,000 milligrams or less, as the evidence suggests those doses are ineffective. Fortunately, since the time the USPSTF recommendation was published, more studies were reported and several systematic reviews were incorporated into an evidence-based medicine guideline in the database Essential Evidence Plus in 2014. To date, 50,000 patients have been studied in 45 trials. Ages and living arrangements varied. The bottom line is that for hip fractures and non-vertebral fractures, the combination of at least 700 to 800 units of vitamin D and at least 1,200 milligrams of calcium appears to be effective in prevention. Vitamin D alone does not appear to work, at least up to the study doses, which, as best I can tell, were up to 800 units. The number needed to treat of 64 for hip fracture is really not terrible. Mild hypercalcemia and uncommonly GI side effects and renal disease were the observed adverse effects of therapy. The next related question, does vitamin D prevent falls in the elderly? The answer is yes, but it really only seems to work in institutional settings, which is odd. Nursing homes, assisted living, and hospitals. This 2012 Cochrane review found improvement in the falling rate, but not the overall risk of falling. Wrap your mind around that one. 5 studies, about 4,600 participants there. As for the elderly living outside of institutions, the USPSTF in 2012 made a B recommendation for supplemental vitamin D to prevent falls, with meta-analyses suggesting efficacy at doses of 800 to 1,000 units a day. Unfortunately, that same year, Cochrane published a review finding no benefit in terms of fall rate or risk of falling, but did state that benefit in folks who were vitamin D deficient at baseline still may be possible. So it's difficult to know what to do with these conflicting findings. I guess thankfully, we already have evidence of benefit in terms of fracture prevention, so maybe this conflict isn't that big a deal. Now, cohort studies have shown a consistent link between vitamin D deficiency and cognitive decline. To date, only one large randomized control trial has addressed this question, and unfortunately, no benefit was found. This study involved women exclusively as it pulled data from the large Women's Health Initiative study. Women were randomized to receive 1,000 milligrams of calcium and 400 units of vitamin D daily, or placebo, and they underwent a battery of cognitive tests annually for an average of 8 years. Intention to treat analysis was used. The researchers found a rate of mild cognitive impairment or dementia of 5.1% in the therapy group and 4.8% in the control group, which was not a statistically significant difference. When patients who were poorly adherent were excluded from the analysis, there still wasn't a difference. So no benefit was identified. Again, a relatively low dose of vitamin D was used in this study, so you can bet larger studies involving higher doses and including men will be coming down the pipe in the future. Next question, how about chronic pain? Well, we learned that osteomalacia from vitamin D deficiency can present with vague, diffuse bone pain and muscle pains. Well, a 2015 Cochrane review looked at 10 studies on a fairly small number of patients, just over 800. As you can see here, the studies were difficult to compare as they involved various diagnoses, vitamin D doses, outcome measures, and co-interventions. Still, no consistent pattern of benefit was seen. This is an area in which better trials are definitely needed. What about pregnancy? I know there are some obstetricians who have already jumped on board with vitamin D testing and supplementation for deficiency, but is there evidence? The answer is a definite maybe. A Cochrane review was completed just last month. The authors looked at 15 trials on over 2,800 women, with 9 studying vitamin D alone and 6 involving vitamin D and calcium. On the whole, the evidence was low to at best moderate in quality. In the vitamin D only studies, serum 25-hydroxy vitamin D levels were found to be higher with therapy. There was a trend towards less preeclampsia, though the 95% confidence interval for the relative risk crossed 1, so it's hard to know what to make of that. There does appear to be a lower risk of both preterm birth and low birth weight with therapy, and very low quality evidence suggests no benefit in terms of gestational diabetes. When calcium is added, that trend toward lower risk of preeclampsia becomes a full-blown lower risk. But the trade-off is that there is a higher risk of preterm birth, unfortunately. So in summary there's good reason to avoid vitamin D and calcium combined in pregnancy for now. There may be some improvement in fetal outcomes with vitamin D alone, along with improvement in lab levels, which of course are of unclear clinical significance. There are larger trials underway, and we should achieve more clarity on this issue soon. For now, the review authors suggest the evidence isn't strong enough to warrant action. Another controversial question for some is whether we really need to medicate breastfed newborns with vitamin D. The American Academy of Pediatrics does recommend doing so. The recommended dose is 400 units per day until the baby is taking in a liter of formula or milk, both of which are vitamin D fortified. The rationale is that even though rickets is exceedingly rare, many of the cases that do occur are preventable. For what it's worth, one small randomized control trial and 2 other small trials have been done, 2 in China and 1 in Turkey. The one RCT started 300 units of vitamin D at 3 months of age, and follow-up range from 6 to 30 months. 17% absolute reduction in the risk for rickets was seen with the intervention. The other 2 trials had significant methodological flaws. This isn't the strongest evidence foundation for our recommendation, so we can't be totally sure we're helping kids by supplementing, but it's not unreasonable, and there appears to be little risk. Okay, last question here. Does vitamin D help with depression? Well, as in so many other arenas, there haven't been many RCTs done yet. I found a review of one study out of Norway in 2012. 243 patients with mild to moderate depression and low vitamin D levels were randomized to 40,000 units of cholecalciferol weekly or placebo. The results showed not so surprising rises in vitamin D levels in the intervention group. Depression improved actually in both groups, therapy and placebo. There may have been stronger improvement in patients with worse baseline depression, but this is something that needs confirmation in future studies. So for now, no proven role for vitamin D in depression. So I have hit you with an absolute barrage of information today. Let's shake it out a minute here, friends. Blink those eyes, do a few gentle neck circles, get those arms swinging, okay? You gotta get up and go to work in a few minutes. But let me leave you with a few parting thoughts. It should be obvious by now that as of February 2016, there's kind of this strange disconnect between what has been suggested about vitamin D in observational studies and what vitamin D has actually been proven to achieve therapeutically. So much promise, but so few evidence-based applications. More questions than answers. If you spend a chunk of this monologue snoozing, fear not, here's the highlight slide. Wake up and look at it for a second, okay? As we await the results of large clinical trials in vitamin D, and I should say there are many currently running, we're probably going to get a ton of data in the next couple of years. I would suggest that our interim strategy should involve humility, patience, and explicit attention to goals. We should be asking ourselves whether vitamin D has been proven to do the thing we want it to do in this situation. If it has, great, proceed. But if it hasn't, maybe we should turn our attention elsewhere. Remember that observational data has failed us before when we tried to take that next step to therapeutic application. And remember that narrow number focused care continues to plague us in medicine. Think about HDL cholesterol. How many people here used to prescribe niacin to try to drive HDL levels up? Anybody? Anybody? Who was doing it? I was doing it just a couple years ago, okay? And how many are still doing it? Anybody? Okay? The same can be said about homocysteine and high sensitivity CRP, and I'm sure a host of other measurable things. These were all clinical passions at one point, but we've learned that even though these lab numbers can predict disease down the road, taking active steps to try to change those numbers does not necessarily help patients. It may help their numbers, but it doesn't necessarily help them. We need to be driven by patient-oriented and frankly patient-agreed-to outcomes. It's great that vitamin D3 appears to lower mortality, but if your 90-year-old doesn't care, you really shouldn't force the issue. Keep in mind, too, that the risks of the whole vitamin D testing and treating apparatus have been poorly characterized to date. Therapy appears to be reasonably benign as far as we know, but we will surely learn more in the years to come. This is what always happens with medical therapies. One of those risks is that with testing 25-hydroxy vitamin D levels, we're barking up the wrong tree altogether. And I don't know this to be the case, but it's a risk. Some authors talk about the idea that this substance, 25-hydroxy vitamin D, appears to be a negative acute phase reactant, meaning that levels drop in the setting of inflammatory illness. I've also read that low levels may simply be a surrogate for physical inactivity and poor health. I saw this really interesting but small study of patients with non-alcoholic fatty liver disease, where patients who went on a calorie-restricted diet for 8 weeks, and they took in less vitamin D, and lost weight, nonetheless saw increases in their serum levels by about 3 nanograms per milliliter over the study period. So what we're testing for may not be the thing itself. It may only be the marker for the thing. We just don't know. We really shouldn't be testing vitamin D levels for any old indication yet, whether it's cognitive decline or depression or unexplained pain or hypertension, because we're adding costs to a healthcare system that is already tremendously overburdened with costs, and we're doing so in a completely unproven clinical endeavor. I love this notion of the heroic search for positive test results. This came from a paper from Archives of Internal Medicine in 1990 that I stumbled on when I was looking for something totally unrelated last year. In the paper, the author basically went through and analyzed all the reasons that medicine had developed an unhealthy obsession with laboratory testing, even in 1990. Various psychological factors, the culture of medicine, situating training in hospitals, and so forth. My concern is that with vitamin D, our healthcare system has fallen into a bit of a trap that is emblematic of this heroic search. We go looking and we find people with low vitamin D levels, and that reinforces our search. We might be missing people with low levels, so we got to test more people. We order more tests, we find more positives, on, and all of a sudden everyone and their brother has been tested and found themselves on 50,000 units of vitamin D a week for 8 to 12 weeks, or maybe 24 weeks because the first round of treatment didn't drive the serum level up enough. The point I want to make is that we shouldn't assume that checking vitamin D levels and treating lab abnormals is helping patients in ways that they care about. Medical technologies, except in rare circumstances, shouldn't just be given the benefit of the doubt based on biologic plausibility. Now, 5 years from now, I may be standing here telling you, hallelujah, the program works, get those levels above 30, and we'll wipe out heart attacks, osteoporosis, and cancer. But it seems just as likely that we'll never prove benefit, or that only marginal benefits to testing and treating are proven. I think the better part of valor is to wait it out. Thank you. So references are here. If I could commend one piece to you guys, there's an article by a guy named Clifford Rosen to the top there, Vitamin D Insufficiency in New England Journal 2011. It talks through all these problems with lab testing. It's a worthwhile read. It's pretty short.
I'm sure there must be a lot of questions. Anyone?
Yeah, well,
Repeat the question, please.
Yeah, so the question is weekly vitamin D versus daily dosing. I mean, you saw that there's a VA study that kind of looked at the dosing regimens, and sure enough, the 50,000 units, basically higher dose ergocalciferol, seems to cause levels to rise more quickly and by a larger amount than the smaller daily dosing. Whether that actually affects patient-oriented outcomes is an open question. That's never been looked at.
Tim, you sort of whizzed through your concluding slide that said the lack of evidence of harms is not the same as evidence of no harm or something like that. Any additional comments on that? You're right that we've been burned on this, and with things like the beta carotenes and calcium, we actually got to evidence of harm, as they kind of continue to unpack controlled trials. I've not quite heard that story with vitamin D yet, but I'm wondering about your thoughts.
Yeah, I'm not expecting some unbelievable harmful thing to come out in the years to come. What I'm saying, though, is that we probably will learn a little bit more about harms, and there's probably more out there than we're aware of right now. The kidney stone thing, it's come up in a lot of these Cochrane reviews, and they just talk about how the data collection on adverse effects has just been poor in randomized controlled trials to date. So it may turn out that there are more kidney stones than we think there are, or something like that. But I'm not expecting some dramatic discovery in years to come.
Well, I think this is the best audience we've had all year. So thanks for your attendance, and thanks very much for a very interesting talk.